Excellent. Welcome to today's National Neonatal POCUS Collaborative Webinar. My name is Arjun Patel, and I will be your moderator today. Before we start, just some general housekeeping items to make note of. The chat is disabled for the audience, but the moderators may send out general announcements via the chat. Please use the Q&A feature to post your questions. There will be a Q&A panel session after our featured presentation. This webinar is being recorded and will be uploaded to the collaborative website at neopocuscollab.com. Now on to our main talk. It is my pleasure to introduce Dr. Yasser Elsayed. Dr. Elsayed is a professor of pediatrics at the University of Manitoba. There he serves as a staff neonatologist, registered echocardiologist, and researcher at Manitoba Children's Hospital Research Institute. He is the founder and director of Winnipeg's integrated hemodynamics and point-of-care ultrasound programs. His programs optimize the management of critically ill newborns by assessing end organ performance. In addition, Dr. Elsayed is co-chair of the International Point-of-Care Ultrasound Group, POCUS Neo. He is a prolific author, an accomplished teacher, and a passionate presenter of his programs and techniques. Dr. Elsayed, please take it away.
Thank you very much. Can you hear me well?
Yes,
Thank you very much,
Arjun,
for introducing me. Thank you for the team, the POCUS team, for inviting me for the second time and this wonderful platform. So let me share the screen and start my presentation to see fine. I hope that you can see the presentation.
We can see it. Thank you.
Wonderful. So the title of this presentation has been really active title for the last few years, and it is typically unveil whatever we have been considering for neck or gut injury for so many years as a true by relying only on X-rays. And now we discovered a lot of things that might affect our management plans for assessment of neck or gut injury. So let me start, and I have nothing to disclose in this presentation. And I have three main objectives with precision. And as you will realize during the presentation, we'll try to be very precise in our outlined assessment. So at the end of this presentation and over the next 30 minutes or so, the attendees will be able to demonstrate the 4 clinical phenotypes of gut injury. So not everything is neck. So we realize that neck is just assume the terminology about any kind of gut injury or ischemia, but the spectrum is much beyond that. And then the triad of gut injury diagnosis focusing on intestinal ultrasound, and then the management bundle as we published of gut injury. And you realize again over time that we are talking about precision in management. So the history of medicine, as you know, that was the start of the experience-based medicine. That's before the era of evidence-based medicine. So everything before 1990s was relying on assessment of clinical diseases based on personal experience, based on what's written in the textbooks. And then beyond the 1990s, we emphasize the importance of evidence-based medicine. And over time, we realized that not all of the questions that we have in clinical practice can be answered by evidence-based medicine. One of the main limitations of randomization of different interventions or medications, that we're assuming that everyone is the same. And over time, we realize that everyone is different, which we still respect evidence-based medicine as the baseline, but we have to respect the personal differences between subjects. And with precision-based medicine, it is mainly relying on two emerging techniques: point-of-care ultrasound, which is now the tool that every physician working in intensive care or emergency should master, and genomics. These are the two main aspects that are very important to integrate with precision-based medicine. So let us now discuss the clinical phenotypes of gut injury in our presentation. We are talking about the spectrum of diseases, not only neck. And as you can see here, necrotizing enterocolitis is just one of them, and it is a disease of prematurity induced by premature gut improper feeding. On top of that, immune response and sometimes ischemia. So necrotizing enterocolitis should be very now within this spectrum. And then number two, compromised oxygen delivery due to hypoxic or ischemic insult, the same as we have in severe anemia, severe hypoxemia, like in congenital cyanotic heart diseases, or shock. And this is definitely should not be considered as NEC. There's acute ischemia of the bowel that might happen induced by decreased oxygen delivery. And then we have intestinal obstruction, and obstruction of the bowel might be one of two categories. Could be due to compromised blood flow, like in surgical emergencies, for example, volvulus or malrotation, or obstruction with normal blood flow, like in a stricture as a consequence of neck or ischemic gut injury. The stricture might happen in few weeks after gut injury, and definitely is not related to blood flow. And then we have the last item, which is food protein-induced enterocolitis or immune response gut injury. This is definitely misdiagnosed as NEC in a lot of entities without relying on ultrasound. So now let us discuss the triad of gut injury diagnosis. And I try to make it triad for more or easier knowledge retention. And definitely I will focus mainly on intestinal ultrasound. In the article, as that you can see in the bottom of the slide, a novel integrated clinical, biochemical, radiological, and sonographic classification. It was a trial from our team to start relying on ultrasound integrated to other radiological interventions and plus clinical and biochemical assessment as a replacement of the old Bill's classification, which is now outdated and misleading in a lot of cases. So the triads, clinical triads, infant stable, that's very important to know. If the infant stable, that's unlikely to be NEC. Infant with NEC should be really unstable or sick. Is there any systemic hemodynamic instability or respiratory instability? If there is any abdominal signs, discolored abdomen or emesis, radiological signs, including for sure intestinal ultrasound, and then abdominal X-ray still should be considered in integration of ultrasound. We are not relying entirely only on ultrasound. You should include X-ray with respect and understanding with limitation of both. And then contrast studies sometimes. And then the lab work, we should integrate CBC, CRB, blood gases, including acid-base assessment and electrolytes. You can find the details and assessment of different modalities in the article as written or as highlighted in the slide. So if we look at the evidence in ultrasound versus X-ray, you can find easily that the sensitivity of the ultrasound suggests that it is between 80 to 100%, depending on the stage of NEC and operator experience. One of the main limitations of ultrasound that is operator dependent. So you need someone well trained, which might take at least up to 1 year of training to master ultrasound. You can consider the second modality in complexity and sophistication secondary to echocardiography. And then specificity of ultrasound range between 80 to 100%, again, making it's a reliable tool, particularly in advanced centers, and also it is based on operator experience. X-ray, sensitivity 44 to 63% in assessment of NEC. And specificity is not even higher. It is 56 to 73%. Also, it depends on the quality of the X-rays, the stage of the disease, and the presence of artifacts. But let us explain more in more details. Again, to make the ultrasound markers in gut injury easier to understand and for easier knowledge retention, I made the ultrasound markers into triads. So 3 things related to air, portal venous gas, pneumatosis, or pneumoperitoneum. And then 3 things related to wall. We have thickness, either thickened or thin wall. We have intestinal signature and also presence or absence of peristalsis. Definitely, you cannot assess that in X-ray. And then fluid related, either simple fluid, peritoneal fluid, complex peritoneal fluid, or dilated loops with fluid inside the loops. And then 3 things related to color Doppler, either normal color Doppler, hyperemia, or no color Doppler can be detected at all, which is a sign of ischemia. So you have 3 multiplied by 4 different categories. And to make it easier also to understand the difference between X-ray and ultrasound, I have a few case scenarios. We have this case scenario here, and just look at the X-ray. We have a preterm infant, 26-weeker at 1 week of age, passed the multiple frank blood per rectum, required intubation for apneas after being stable on CPAP for the last 2 days. Unremarkable CBC and the blood gases. And because of the blood stool, the team concerned about NEC. So you have the X-ray in front of you, and this X-ray was reported by the radiologist and also interpreted by our team as pneumatosis. And you can see translucencies. I think it's obvious in multiple areas in the column here as well. So would you keep this infant MPO and stop antibiotics? So this is the main question. Probably in absence of ultrasound, you would do. You have an infant who is intubated and you're not sure why at this time, and also passing blood stool and X-ray reported as NEC. The ultrasound was done. And the ultrasound was done and the almost the same area, the left part of the bowel suspected pneumotosis. You can see peristalsis and good perfusion. Once you see peristalsis by ultrasound, that's the most reassuring sign. Sick bowel should not move. The sick bowel, either when you see septic areas and no peristalsis, or you may be able to see other signs of NEC, like no peristalsis, no pneumatosis or so. If you see no peristalsis and no other sign of NEC, that could be septic area simply. But once you see
Dr. Elsayed, I apologize for interrupting. We're having some audio issues on our end. Maybe if you can try switching out the headphones.
Okay.
Try now.
Is it better now?
Much better. Thank you. Sorry for interrupting.
Yeah, that's fine. Yeah. Thank you for letting me know. So as you can see here, you have very good peristalsis and good perfusion, and that's by itself very assuring. So the infant was already started feeding without any hesitation. And what you could see sometimes in X-rays misleading is not pneumatosis. I have this terminology from Dr. Joseph Nayo, which he likes to call it as apoptosis. So that's really one of the misleading signs from X-rays. I have another case scenario, and this case was actually performed and interpreted by Dr. Hanifi Soilo, who's among our panelists today. We have twin delivery at 28 weeks, di twin, unremarkable prenatal history. And at day 8 of life, this infant passed, one of the twins passed the blood per rectum. So CRP less than 1, X-ray had suspicion of pneumatosis. Without going into the details, the ultrasound was done, and the ultrasound was reassuring. Again, as you can see, normal peristalsis, normal perfusion. And then 1 day later, the previous infant already started feeding. 1 day later, or almost the same day, the twin A has had multiple blood stools, abdomen,
was slightly distended, and the X-ray, as you can see, very reassuring. Normal gaseous pattern, CRP still less than 1, and the X-ray reported as normal, as per radiology. And then the ultrasound was done. I think obviously you can see bubbles moving in the portal veins, signifying portal venous gas. And multiple loops with the pneumatosis, its analysis in multiple areas, although there is a lot of air affecting the quality of the image. But this infant was considered as NEC. 8 hours later, this infant had CRP jumped up to more than 50. And second day of life, this infant passed away from involvement in neck, severe shock and involvement in neck. In the article, we actually compared the area under the curve at the same article between relying on ultrasound and relying on X-ray as reported, without ignoring the ultrasound finding on those infants with known outcomes. And what we found, the area under the curve for ultrasound is more like close to 90% compared to relying on the X-ray is about 74%, which is consistent with what has been published before, the sensitivity specificity, ultrasound versus X-ray. So typically in 50% of translucencies in X-rays that you can see is just impacted fecal mass compressing the air between the wall and the fecal mass and giving false impression of pneumatosis. So just to go through our topic with assessment, the technique of abdominal point of care ultrasound and assessment of the bowel, we assess the liver in 2 perpendicular planes in right lobe and left lobe with 2D and color, and then assess each of the 4 quadrants in 2D and color in 2 perpendicular planes, and the assessment of the midgut. And when we assess the midgut, we have to look at the orientation of the superior mesenteric artery and vein to rule out volvulus or malrotation. So if you see wire pull sign or the vein wrap around the artery, then you have a big concern about malrotation. So this is a protocol in brief, and just I'll go over some of the signs that we see in ultrasound. So you have the pneumosis signalis on the left side of the image here in multiple cases. And then we have the normal peristalsis. Sometimes you can see air, which is concerning as it could be air related to pneumatosis or normal. When you apply pressure by the probe and you see peristalsis and the air is moving away, this is normal. But the loop with pneumatosis should not move, will be fixed loops. And then the portal venous gas can be massive portal venous gas, as you can see here in the ultrasound on the left side, or which can be seen in X-ray. You can see this massive portal venous gas in X-ray also clear, but the mild portal venous gas in the right side image is missed on the X-ray. You cannot see it by X-ray. You'll only see it by ultrasound. And this mild portal venous gas is not only seen in neck, it can be seen also in protein milk allergy, which in a situation you should not stop feeding, you just change formula to hypoallergic formula or hydrolyzed formula. Perforated bowel typically should be assessed by X-ray. Free air, the X-ray is a gold standard, but also you can detect it by ultrasound. As you can see here, the liver, you can, when you put the probe over the liver, you'll see the air lines artifacts, or vibration artifacts related to the air. And this can be, again, seen by X-ray, very easy. But when you have contained air or encysted air will not be seen as free air on the X-ray, will only be detected, like in this case I'm showing to you, was recently in our unit, and the X-ray was just reported as dilated bowels, but it was actually contained air, and this infant underwent operation due to perforated bowel. That was missed typically in the X-ray. The bowel wall, as you can see here, you have a bowel wall with detected 5 layers, which is very reassuring when you see the bowel wall signature, and you see the hypoechoic musculosa, which is number 4 layer, and the second layer, number 2 here, which is mucosa, they are well perfused. That's why you see these layers are hypoalcoholic. And typically you can see 5 layers. The first one is the interface between the mucosa and the bowel content. Number 2 is mucosa. 3 is submucosa. Number 4 is musculosa, which is thick and hypoechoic. Number 5 is serosa. When you magnify the image, you will see the 5 layers, which is really reassuring about well-perfused bowel. But in the right side here, you can see very thickened bowel. I'm using the thickness of the jejunum, because jejunum is the most thickened part of the bowel, and you can measure the thickness. If it is exceeding 0.26, it is a marker of ischemia. And also you can detect that the bowel signature is lost. Here you have the hyperemia, and the hyperemia, as you can see, can be Y-shaped hyperemia, significant hyperemia, and in between you have very echogenic bowel. Here you apply 2x2 color box, and you can see only artifact color, but there is no perfusion detected. This infant had severe ischemia, and that was confirmed by during the OR. This ultrasound was done just half an hour before OR. And in the OR, the same infant, the bowel was very ischemic. In this infant, the surgeon could not do anything, could not remove the bowel for sure, and the infant passed away. When we discussed with our radiology team, please just be careful when you report X-ray as NEC. The NEC is a syndrome. It's like a collection of multiple modalities, biomarkers plus X-ray. So the X-ray should be reported as, with considering limitation, as translucencies. So this report, I take this report as an example from one of our wonderful radiologists, and what he mentioned here in the X-ray suspected as pneumatosis, and this X-ray was actually confirmed the same patient as normal by ultrasound. Best visualized within the mid-distal descending colon as multiple tiny translucent hyperlucencies concerning intramural gas. This would be best confirmed by point of care ultrasound. This was written by our section head of pediatric radiology, was considering the significant limitation of the X-ray. You have the details of the modality already explained in this article, like how to integrate between ultrasound and different biochemical X-ray plus clinical assessment. And our integrated approach can be summarized here as mentioned, as detailed in the article. When you have a suspicion of neck or gut injury, get workup, which is CBC, electrolysis, CRP, X-ray, plus ultrasound. We are not ignoring X-ray, as I mentioned. And then get the physician expert in ultrasound, who's the same physician expert in assessment of gut injury, who can integrate between all of these markers. If the infant's stable, clinically stable, which is very important to keep in mind, if you have normal ultrasound, normal lab work, continue feeding. And even if the X-ray reported was whatever, this is, you have normally clinically normal infant with normal lab work, plus reassuring ultrasound. If you have normal ultrasound or mild markers like very localized pneumatosis or so, and you have eosinophilia, leukocytosis, thrombocytosis, not thrombocytopenia, with or without anemia, this combination is very common to be seen as food protein-induced enterocolitis or cow milk allergy, as the old name known for this condition. So consider to change the formula and ask a mother to quit dairy products, change the formula to elemental, hydrolyzed formula. But if the infant is symptomatic, unstable, if the infant's unstable and you have to add blood culture, start antibiotics, but if you have mild ultrasound markers like localized hematosis, like the ultrasound markers are not global in the abdomen, just localized, you can follow up with ultrasound on daily basis or every other day. Keep MPO for variable period. We don't stick for 7 days or 14 days anymore. It is based on the case response and the case severity. It can be 4 days, it can be 5 days. Once you have the bowel normalized as movement, peristalsis, and normalized CRP and CBC, you can start feeding as soon as you have the infants ready for feeding. And then if they have significant ultrasound markers, with X-ray, could be with perforation, with confirmed severe NEC. You need to keep the infant without feeding and antibiotics for longer period of time. Again, it is variable based on the case. And once you have the ultrasound normalized and the clinically normalized and recovered markers, including CRP, then you can start feeding. One of the other conditions that typically will not be detected by X-ray or even contrast, the milk beeswax or lactobeswax or inspissated milk syndrome. I have multiple images. This condition can be serious enough to induce surgical intervention because you may have obstructed bowel. In this condition, you can see the milk contrast because of the milk reaching the fat, and the fat will make a contrast, as you can see here. But otherwise, you see good perfusion, no other signs of neck or bowel injury, and very echogenic bowel content and with peristalsis. This milk beeswax, what you need to do, just slow feeding. You can change the formula. You can take off the additives like HMF from the feeds. And you can change the feeding type or prolong the feeding, like over 30 minutes or over 1 hour. Instead of bolus feeding, you can modify the way of feeding, but not to keep the infant without feeding. So that's a milk beeswax. It is kind of mild digestion. It's more common in preterm infant. We have some red flags related to the cases with might require surgical interventions based on our experience. And how we build our experience, we assess with ultrasound and ask a surgeon that to attend the surgery ourselves after doing the ultrasound, take videos or images and compare the pathology during OR with the ultrasound. And over many years, we build up our experience. The red flags that we can see on ultrasound, if you see global thickening or thinning of the bowel, global means all of the 4 quadrants, global absent wall signature or echogenic walls, complex peritoneal fluids, global absent perfusion by color Doppler. These are the red flags. And usually these are associated with sick and clinically unstable and worsening biochemical markers or perforated gut. The expected timing for each marker to resolve, if you have portal venous gas, it usually disappears within 24 to 48 hours. If you are unable to pick up that during the first 1 or 2 days, it will disappear from the portal veins. The pneumatosis takes about 48 to 72 hours to disappear on ultrasound. Thinning or loss of signature usually takes longer time because it's a sign of significant ischemia, up to 7 days. Pneumoperitoneum, up to 7 to 9 days. And then complex ascites, thinning of the bowel, might take longer. So these markers are very helpful to guide us how long we should keep the infant MPO and when we should start feeding. And now I have the three main conclusions for today. Instant ultrasound is very sensitive and specific, but keep in mind the limitations of the ultrasound. The main limitation, it is operator dependent. The other main limitation is the presence of artifacts like air. When you have too much air in the abdomen, you may not be able to see the bowel very clearly. That's why we have some techniques to overcome that, and which we might discuss after the presentation, during the discussion, how to overcome presence of significant artifacts in the abdomen. We have special tricks to do to overcome that. And then the gut injury has 4 main phenotypes. Not everything is NEC. NEC is terminology specific to preterm infant related gut injury. But we have, as I mentioned during the presentation, ischemic gut injury related to congenital heart disease. We have gut injury related to shock or related to surgical emergencies. And don't forget protein milk allergy, which misdiagnosed in a lot of situations with NEC and also milk beeswax. And then integrating ultrasound, X-ray, biochemical markers, and CRP helps to identify surgical emergencies. That's why the ultrasound that we prefer and recommend to be done for assessments point of care, to be done by the clinician, by the person at the bedside who's able to integrate all of these markers at the same time. And he's at the bedside and he knows if the infant is really sick enough and when to intervene. Thank you very much.
Excellent talk. Thank you so much, Dr. Elsayed. We'll now be moving forward with our Q&A expert panel discussion. Please put any questions into the Q&A and I'll relay them to the panelists. Joining Dr. Elsayed, we have Dr. Soylu and Tutman. Dr. Hanfli Soylu completed his pediatric residency in Turkey, his master's degree in clinical epidemiology at Newcastle University in Australia, and his PhD in pharmacology at the University of Manitoba, Canada. In addition to his neonatal training in Canada, he has also completed a point-of-care ultrasound fellowship at the University of Manitoba. Dr. Jeffrey Tutman is an assistant professor of pediatric radiology at the University of Colorado School of Medicine. He is director of ultrasound for pediatric radiology section at the Children's Hospital of Colorado and has a specific interest in ultrasound for neck and midgut volvulus. I have some questions from the Q&A currently. First one is, with respect to the clinical scenarios mentioned in this presentation, in the first scenario, does seeing good perfusion, is that enough to rule out gut injury?
Probably I would like to maybe ask our panelists, Dr. Hanifi Soylu and Dr. Jeffrey.
There are many stages of the gut injury, like not only perfusion, the other markers like the bowel thickness or thinness, and also the perfusion sometimes could be high. That doesn't mean that everything is normal. Actually, it could be a sign of the severe inflammation at the initial stage. So relying on just perfusion, I think is not fitting with the whole picture. So that's why we are using with the other aspect of the intestinal ultrasound, like a peristaltism, and then the also thickness and thinness, perfusion, if there is any complex fluid in the abdomen, and the pneumatosis intestinalis and the portal gas, if we are able to see it. So even like I'm not ignoring the importance of the radiology, because sometimes we can see the first thing as a pneumoperitoneum as in on the X-ray. So I mean, it should be all together. That's why I think Dr. Yasser was mentioning about the integrated approach to this clinical picture. So from personal opinion, it cannot explain the whole picture. So we should add the other markers to understand better what is going on.
Yeah, I would totally agree with that. I think really looking at all the findings and putting them all together is critical for making an accurate diagnosis. Like you said, the operator dependence of ultrasound, the color perfusion of bowel can be a challenge with that as far as how your machine is set. Alongside of that, another question I would pose to you two is are you using contrast enhanced ultrasound at all? We found that to be, we've done a few cases where we have used that, and I think it's much more sensitive for evaluation of bowel perfusion. It's a much more comprehensive picture. I'm curious if you have any experience or if you're utilizing contrast enhanced ultrasound at all for ultrasound for neck.
We don't use, unfortunately, that one. But I heard, or just I saw many articles about is increasing the sensitivity and specificity, especially for the perfusion-related problems as well. So I'm believer it could be worthwhile to include that one to our clinical assessment tool. But from my side, I have no personal experience about that.
Excellent. Next question I have here is, compared to KUB, which can visualize the entire abdomen, abdominal ultrasound seems to only visualize 5 areas of the abdomen. Can you possibly miss an area of injured bowel on abdominal ultrasound?
So, please go ahead. Then I will add if there is something.
Okay.
Must not the radiology related question, but I will add the other part.
Okay, thank you very much. That's a very common question. A lot of our colleagues, they worry about missing like a piece of bowel that cannot be seen. Typically, the bowel is really long in the abdomen. Is actually, as you are viewing a bunch of like spaghetti like inside the box. But the idea is when you assess a bowel, like dividing the abdomen into compartments is really helpful. But when we look at the bowel, we actually try to look thoroughly for different like positions, including the midgut and also the flank. I did not explain the technique in details because that is time consuming. You need a workshop like one day to explain that in details. We look at the colon, including all of the aspects of the colon. From the phalanx, you have to go more lateral and sometimes a little bit posterior to be able to visualize the colon in details. And you look at the watershed areas of the bowel, which is the most affected areas, the hepatic flexure of the colon, and the ileocecal area, the sigmoid colon, the left colon. These are the watershed areas that are early affected by ischemia. So you need a special technique to look at all of these areas, and it's a little bit time consuming. But the idea is, if you are worried about missing any small piece of the bowel is integrated all together. The bowel is talking to each other. So you cannot have like very small piece, very sick, and the rest of the bowel is happy and moving and well perfused. So usually the bowel gets sick as a part, and usually the very sick bowel will be globally affected. So that's like I never seen my experience like very small piece of the bowel is very ischemic, and the rest of the bowel is very happy, moving with peristalsis, perfusion, and no peritoneal fluid. That's why that's very unlikely or extremely unlikely. And even when you have very localized area of the bowel, usually it is not really gut injury. It might happen in conditions like protein allergy, cow milk allergy. You may have very localized pneumatosis, which can be detected in X-ray or ultrasound, but the rest of the bowel would be normal. And continue feeding the infant for this situation is still okay because they have more than 90% of the bowel is still healthy. We just change the formula to hydrolyzed formula, and we never encounter any complication of that in the last 10 years. Yeah, but Hanif, you can add on if you like, or Dr. Tutman also.
I think, yeah, that I prefer to listen Dr. Tutman first, and then I can add if I have something.
Yeah, I totally agree with everything you said. The only thing I would add is I view the two modalities as complementary. We don't have to choose one or the other. At least in my practice, I would say we rarely do an ultrasound without having a radiograph that's been done relatively recently. So we have that information to go off of. So oftentimes I'll interpret them together, and I use them to sway how I might interpret one or the other. So we don't necessarily have to pick and choose one or the other. I view them as complementary, like you spoke about.
Thank you. And from my side, I will add many times they are calling us for the spontaneous intestinal perforation cases to see if it is a neck-related condition or just isolated condition. So when we do this baby's evaluation, we see the whole intestine, and then I don't remember if we missed anything so far. When we say this looks like a spontaneous intestinal perforation, it looks like a mostly spontaneous intestinal perforation. But when we see the other parts of the bowel is sick, then we can identify this not the simple intestinal perforation problem. Mostly could be neck-related issue. So, and then if this is the case, like a 5 quadrant, we are just only assessing. It is not true impression. So we are making this one. If you consider baby is tiny, and then the probe is relatively not small compared to baby size, I don't think we are missing any area of the bowel by screening with ultrasound. So, and then plus we are evaluating many other things that the simple X-ray or the other techniques are able to catch, like a perfusion, like a peristaltism, like a tiny amount of the fluid, like the perforation area, if they're healthy or not, the other side. So that those not easily to identify by the radiological techniques compared to the intestinal ultrasound.
That makes sense. Thank you. The next couple questions are more systems level questions. This one is, what are your unit's approaches to standardizing the diagnosis and availability of ultrasound for NEC 24/7? Are all NEOs trained in this approach, or is pediatric radiology taking up some of this burden?
I prefer Dr. Tutman can share the experience with their unit, and I can tell what we are doing. So I don't know, what is your opinion there?
Sure. Yeah. So I think this is going to be variable across, geographically. So I think the United States is probably going to be different from other countries. So at least, and then I think even there's going to be variability amongst institutions as well. So at least in my practice, this is largely driven by pediatric radiology. We have pediatric sonographers that are doing all of our scans for us, and then the pediatric radiologist is interpreting them secondarily. I know that varies from other countries where the radiologists are doing the scans themselves, and the sonographers are not a widespread profession in other countries. So I think there is going to be a significant amount of variability just based on kind of your local practice. But at least for us, even amongst pediatric radiologists, I'd say there's variability in kind of comfort level and expertise with this. I practice in a group of 20 to 25 radiologists, and there's probably 4 or 5 of us that have a specific interest and expertise in bowel ultrasound. And then we have about 35 or 40 sonographers. So getting them all trained and developing their expertise is a significant challenge as well. So I would say at least in my institution, I believe most places in the United States, this evaluation of necrotizing enterocolitis is largely driven by pediatric radiology and pediatric sonographers.
So I totally agree. There are many institutional differences because this is not like a commonly accepted area that there is no consensus too much between the units. From our perspective, in our unit, there are a couple of colleagues. We are doing intestinal ultrasound. That Yasser presented the case, the second case, actually, it was 4 a.m. I was going to home, I was on call, and then everything was normal. By the radiology reported the abdomen is normal, and we know the previous twin has the same story, and then everything was normal. So it was like most likely was everything normal. CRP was good, and then the clinical examination was not remarkable. But even I was not very happy. Let's see what is going on in the abdomen. So, and then when I put the probe, immediately I saw in the liver there is a portal gas. It's also portal gas is going there. So that is kind of saving the time. Unfortunately, that baby passed away. But if you think about the compare to cold radiology, the technician will come and then do something, and plus what you are doing in 2 minutes. The most important thing, are you able to interpret what you see? So in this kind of situations, we are backup people like experience in this area, like Yasser, and then we have another colleagues. We just calling them. We're just calling and then sending the images, and then sometimes we are doing this one at the bedside. It's making everything much easier and much more practical and quick. And then you can immediately start antibiotics, putting baby MPO. I don't think this is available with the other concept. So this concept looks very quick and very practical from my perspective.
Yeah, thank you very much. I would like just to add one more thing to also advise to other colleagues and other centers. It's not that easy to learn the intestinal ultrasound. It's not the same like lung ultrasound, for example, or kidney ultrasound. It's a technique that you make a critical decision, because you might suggest your colleague, the surgeon, to go to the OR. So it's really critical decision. That's why it's a collaborative work between the trained team in the NICU. And in Winnipeg, we have a good number of people already trained or being trained on ultrasound. Plus, we have our colleagues from radiology that we can ask questions or get the ultrasound from the radiology team to integrate and help so that you get much more clear overall picture to the surgeon and feel confident that this infant should go for surgery. And almost for the last 10 years, we haven't had encountered any significant issue with this approach when the surgeon actually has to go and regret that I should not have considered surgery in this case or so. With making this kind of integrated collegial approach between the surgeon, the intensive care team, and the radiologist all together. And sometimes we meet together to discuss the case in details and go over the images. We have the most important to have a very clear curriculum on training and very structured training, which should be nationally approved. So 2 years ago, myself, Maki, and our colleagues from the American Academy of Pediatrics, we published 2 guidelines on the use of point-of-care ultrasound. And the 2 articles, one of them is talking about the details of the approach itself overall and the medical legal aspects and the training approach. And the second article is the technical guidelines. And both, for sure, like any other American Academy of Pediatrics guidelines, they are open access, so anyone can access them and read the details. And we have also in Canada, the Canadian Pediatric Society, we published that a few months ago. It is also the statement guidelines to guide the institution how to implement these techniques, not only about intestinal or abdominal ultrasound, about all of the other point-of-care aspects. So if you should have a system and a very clear curriculum at your institution to implement the technique and how to train the team safely. And that's written in brief in the article. In some institutions, and like in our institution, we have 1 year training in point-of-care ultrasound integrated to the neonatal fellowship program. But because worldwide, we have a lot of colleagues interested to join training through the Canadian POCUS Society. And we are members, and I'm the vice president of the society. We introduced for the last 2 years the diploma program, which helps those colleagues outside North America to gain the experience. So there's a curriculum, there is a training, they have to send the images and get evaluated, and they have to finish certain course modules, and they have to pass the exam. There is exit exam at the end. And we already introduced the program. And by the way, Hanif is one of the instructors in the program with us on lung ultrasound and cardiac point-of-care ultrasound. And we are planning in the next year or so, we also considering to introduce the abdominal ultrasound in this training approach. It is comprehensive training. It takes about 6 months to finish, but it is kind of alternative for those who could not join training as like a dedicated fellowship in North America.
Yeah, that sounds like an excellent service to our community.
I think
thank you for
Yasser,
plugging that.
can I add, Yasser? I think like training is very important, but from like our institution wise also, like post training case discussion is also very important, because sometimes you do intestinal ultrasound and then you are not sure about what you see. So at that case, if there is anybody to discuss this one, then you are learning more and more. Like it is, I don't think it is just training limited learning in this kind of a little bit more complex compared to the lung ultrasound, like intestinal ultrasound. But if there is a backup person, it is much easier to learn, and then it is faster, based on my experience.
One thing we've discussed here is the idea of having almost 2 different types of protocols for varying levels of expertise. So, the full protocol involves all the different findings you talked about, the peritoneal findings, the fluid, the bowel, all those very, comprehensive scans. there's been this idea of a more limited protocol where you're, I think the most challenging part of the exam is looking at the bowel, but I think most people could look at the, the peritoneal findings of, if they're complex fluid or simple fluid or, portal venous gas. I think some of those findings are less in need of the degree of expertise that it takes to look at the bowel. I'm curious what you guys think about that approach. It's not as comprehensive, but looking at those peritoneal findings, you can see a lot of the more significant findings of, complex fluid or, peritoneum, or some of the more findings of end stage or more severe neck. I'm curious what you think about that type of approach for centers that might have less expertise.
Yeah, definitely. We actually highlighted that in the guidelines for both the American Academy of Pediatrics and the Canadian Pediatric Society. The first article we highlighted the difference between the study that should be conducted by the radiologist focusing on the detailed anatomy. Usually it is not very urgent, and then describe the pathology in details about all of the abdominal organs, versus a focused approach. You have infant who is sick and you are suspecting either gut injury or neck, or could be volvulus. You have a specific diagnosis in your mind and you need to rule it out. So you need to modify your assessment based on the clinical consequences or what's expected clinically. And that's more for the urgent cases. Usually the point of care ultrasound dedicated for urgent infants who's really sick, crashing or being crashed, and you need to have an answer as soon as possible. If the bowel is really ischemic or there is volvulus, you need to rule it out. And that's why you have specific markers. And it should not take long time. It should be focused and specific for that indication of the clinical assessment. That compared to you guys, you come and do very detailed assessment on more elective basis. If you are suspecting intestinal obstruction, Hirschsprung or whatever disease, and you do our liver issue, you do assessment for the anatomy and the specific pathology in more details. We mentioned that in the articles in kind of brief, but that's like the approach. That's what the point of care ultrasound designed for. We have the approach is specific for the questions. You have a specific clinical question that you need to answer, and you have the clinical assessment plus point of care to as a driven technique or to complement your assessment.
Just one sentence before the next question. I should also mention Dr. Alan Denneman's name in this because he's an excellent radiologist from Toronto. And I got a big chance to work with Dr. Denneman there. And then he was one of the pioneers about the intestinal ultrasound in newborn babies. And then we learned lots of things from Dr. Denneman.
Yeah, like definitely. Like here, I remember when I was in Toronto during my echocardiography training, he reminded me about very important things that to overcome the air in the abdomen, you have to apply too much pressure. That's why it's ultrasound is a little bit painful technique when you do for infants. When you put the probe superficial of the abdomen, you'll see only air lines or artifacts. You need to apply pressure, and then after you apply pressure, you'll start to see bowel. That was the first point. So definitely, thank you for reminding us.
Got it. Thank you all. Next question is a little bit more technical. Which combination of findings has been shown to most accurately predict progression to surgical neck?
Probably I can answer, and happy to hear all.
Yes, sir, your sound
Dr.
is...
Tutman and Dr. Soilo. Can you hear me well?
It's cutting a little bit in and out.
Can you hear me?
Yeah, it's a little better now. Go ahead.
Yeah. Okay. So my legs that you consider for surgery, when you have global ischemia, so you cannot see clear color Doppler in the abdomen, thickening of the bowel without peristalsis or global thinning of the bowel and in response to ischemia. And you have complex sedated fluid in the X-ray or the perforation that you cannot see in X-ray, which is contained. These are the most common red flags that we see. Jeffrey, you can add whatever from your experience from what I said.
Sorry, you're cutting a little bit, but from my perspective, there's a nice meta-analysis that was published a few years ago out of our colleagues at Cincinnati, or at Kansas City, who've done a lot of work on this. So they looked at different findings of what the odds of proceeding to either surgery or death were. So it was kind of interesting because of, the findings that we really, I think, focus on with radiographs, and that being portal venous gas and pneumatosis were really not associated with progressing to need for surgery or for death. But a lot of the findings that we can't see on X-ray, so main things being bowel wall thinning, complex fluid collections have a very high odds ratio for proceeding to death or surgery, and then pneumoperitoneum being the other obvious big one for perforation. So those are the main ones I think about, either perforation. Complex fluid, I think, is kind of analogous to perforation, just being perforation that's leaking fluid from the bowel rather than air, and then bowel wall thinning, and then, like we talked about, absent perfusion as well, being the other big one.
Excellent.
Agree.
Anything to add, Dr. Soilu, before I wrap up?
No, I agree. I mean, like the complex peritoneal fluid is one of the most important finding, and then the ischemic area, like there is no perfusion, is one of the red flag for us. And then sometimes we are comparing the area because not all the bowels are getting ischemic. If we see like a different like activity in the bowel, but there is one segment is behaving totally different than the others, and especially that segment is like very echogenic and then also has no perfusion. It is one of the signs for the necrosis there. So usually we are just informing the surgery about this.
Excellent. Well, thank you to our speakers and panelists for sharing their expertise, and for all of you for joining us. Join us next month for October webinar. We're one of the founders of PD SonoFest. Dr. Stephanie Leung will be talking about gamification in POCUS. Registration will soon be available through our website or the QR code on the screen. It will also be sent out through our listserv, which you can sign up for via our website, neopocuscollab.com. In the chat, you'll see the link to the website where you can also find recordings of our previous webinars. Thank you, and we'll see you next month.
Thank you.
Thank you.